In this section, we talk about the example of a situation in which there is going to be an irreversible injury to the cardiac tissue and the clinical condition is given the name of myocardial infarction. As we have discussed in the previous section, when we talk about the pathogenesis of unstable angina, similarly what we find in this kind of a situation is that there is going to be the presence of an ulceration of the plaque, or there is presence of a rupture of the plaque, or there is presence of a hemorrhage of the plaque. As a result of all of these, what is going to be seen is that there is going to be an exposure to collagen and there is going to be a presence of platelet aggregation. The net result that we find is that this is going to be associated with the presence of thrombus formation in the coronary vessel, and there is going to be presence of a coronary artery spasm. Because of both these factors, that we are having the presence of a thrombus formation in the coronary vessel or we are having the presence of a spasm of the coronary vessel, what we find is that this is going to be responsible for causing an occlusion of the coronary vessel, and this kind of an occlusion of the coronary vessel is going to precipitate the development of an infarct in the cardiac tissue. So that condition is going to be given the name of myocardial infarction. Now, clinically speaking, when we talk about myocardial infarction can be of two different subtypes. Possibility number one, that we can be having a situation in which there is going to be the involvement of complete thickness of the myocardium. If there is a complete thickness of the ventricular wall, that is what is going to be given the name of a transmural myocardial infarction. Or possibility number two that we talk about over here is an example of a condition that the most sensitive zone in the cardiac tissue, which means the innermost 1/3 part of the ventricular wall, that means the subendocardial area is going to be having a damage. So that condition is going to be given the name of subendocardial myocardial infarction. So complete thickness of the ventricular wall being affected, that is transmural myocardial infarction. The inner 1/3 of the ventricular wall being affected, that is what is going to be given the name of subendocardial myocardial infarction. If we are familiar with that basic concept, the next important thing that we need to have an idea happens to be the yield points with respect to the clinical manifestations of these patients. So patients who are going to be suffering from myocardial infarction are going to be having the presence of severe chest pain. As we can recall from our applied anatomy law and knowledge, that this kind of a chest pain may not be only limited to the chest area or the precordial area, but this can be having its radiation on the inner side of the arm. It can be having its radiation, it can go to the jaw, and in a lot of patients it can even be having a presentation, it can be going to the epigastric region. Why that becomes important for us to understand is because of two simple facts. The first thing that they love to ask us on the board exam happens to be that the pain that is going to be experienced by these patients is an example of a crushing type of a pain. So the patient gives you a classical history that, hey doc, I am going to be having the presence of a squeezing sensation or a constricting sensation in my chest. This is an example of a severe pain experienced by the patient, which in the words of the patient, he has never ever experienced earlier. So patients classically present with a clenched fist, which is going to be denoting the presence of a squeezing or a constricting sensation in their chest in the precordial area. Such an example of a situation in which the patients are going to be having a squeezed fist or a clenched fist placed on the precordial area is what is being defined in our textbooks as by the name of Levine sign. Fact number two about which we need to have an idea in a real world situation, not every patient having a myocardial infarction is going to be having a chest pain. Patients can be having an atypical presentation in the sense that patients can be having the pain radiating to the inner side of the arm, patients can be having a pain radiating to the jaw, or they can be having an epigastric pain. Why this becomes important for us to keep in mind is because of the fact that if you have a patient who is presenting in your medical ER room with the complaint of epigastric pain, it's a usual thing for a lot of people to think that this is a pain which is attributable to gastritis or peptic ulcer disease. However, as a dictum, please remember middle-aged to elderly patients, if they are presenting with atypical presentation like inner arm pain, like the presence of jaw pain or the presence of epigastric pain, it is always safer on your part to get an ECG done to rule out the cardiac cause of such a pain in the patients. Fact number 2 about which we need to have an idea, there are going to be situations when the patients are going to be having myocardial infarction, but there is going to be no chest pain in the patients. This is what is classically seen in case of patients who happen to be either very elderly patients, or it can be seen in patients who are going to be suffering from something like diabetes mellitus. So patients who are going to be elderly patients or patients who are going to be suffering from diabetes mellitus may be having a heart attack or myocardial infarction, and they may not be having the classical retrosternal chest pain. Such an example of a condition is what is going to be given the name of silent myocardial infarction. Apart from the chest pain, a lot of patients suffering from myocardial infarction are going to be having other clinical manifestations. Say for example, the patients are going to be having profuse sweating, which is given the name of diaphoresis. These patients are going to be having the presence of increase in their pulse rate. This is usually because of the increase in the sympathetic activity. Apart from the fact, patients are going to be having the presence of difficulty in breathing or dyspnea. This can be attributed to the presence of development of the acute pulmonary congestion in these patients. And the patients quite frequently are going to be having the presence of nausea as well as vomiting. So not only chest pain, but the patients can be having the presence of extreme sweating. Patients can be having a very high pulse rate. They are going to be having nausea and vomiting, and the patients are going to be having a difficulty in breathing. Such a patient presenting in our ER is supposed to be evaluated to have a diagnosis made of myocardial infarction. And when we want to make a diagnosis of myocardial infarction, what is definitely important for us to keep in mind is going to be a simple fact that we have talked about in the section on atherosclerosis. If we just recall the basic fact that the most important blood vessel that is going to get affected because of the presence of an atherosclerotic obstruction, this happens to be something like the left anterior descending vessel. And as we had talked about the fact earlier, let us just recall that the left anterior descending vessel is going to be supplying the three important parts of the heart. So the LAD or the left anterior descending vessel is going to be supplying the apex of the heart. It is going to be responsible for supplying the anterior wall of the left ventricle. And it is responsible for having its supply in the anterior part of the interventricular septum. So what is easy for us to appreciate is that if a patient is going to be having an involvement of the left anterior descending artery, all these three areas of the heart, that means apex, the anterior wall of the left ventricle and the anterior interventricular septum, are going to be having a reduction in their blood supply. For this fact, what is known to a lot of us, it is the anterior wall MI that is going to be most commonly observed in the clinical setup. Anterior wall MI is the most common type of myocardial infarction that we see clinically, simply because LAD happens to be the most commonly affected coronary vessel. Now, when we are supposed to make a diagnosis of this kind of a condition, the diagnosis of this condition is made on the basis of several tests and different parameters. The first important example of a test that is being done in a ER happens to be something like the ECG or the EKG. What we find in these patients are going to be the presence of ischemic changes. And when we talk about these ischemic changes, as we are familiar from our knowledge of cardiac electrophysiology, are going to be characterized by the presence of hyperacute T waves, patients are going to be having quite frequently the presence of development of ST segment elevation. Recall the fact that when we were talking about a patient who was having a reversible cardiac tissue injury, that means we were talking about the subendocardial ischemia, which was associated with stable angina. The patients were having ST segment depression. But in a patient who is going to be having an irreversible cardiac tissue injury, the patients are going to be having the development of ST segment elevation. We have situations in which the patients could be having the presence of an old myocardial infarction or a previous myocardial infarction, and those old myocardial infarctions are going to be detected with the help of something that is Worth recalling over here, what is being given the name of presence of Q waves. So usually a patient presenting with the classical manifestations having this kind of a ECG manifestation is going to be having something like myocardial infarction. A second test that is very promptly being done for these patients who are going to be suspected to be suffering from myocardial infarction happens to be the estimation of the cardiac enzymes. A very high area from the perspective of framing questions in our exams as well. When we talk about the different cardiac enzymes, the names of these different cardiac enzymes happens to be an enzyme like myoglobin. We have an enzyme which is going to be given the name of creatine kinase enzyme. We have a third enzyme which is being given the name of the troponin enzyme. This is having two different forms, troponin T and troponin I. And we have got an enzyme which is being given the name of the LDH enzyme. Let us just try to recall the important features of each of them, which are important from the perspective of not only management of a patient but also which are helpful for cracking the questions asked in our exams. When we compare these four important enzymes, it's important for us to be familiar with the fact that the first enzyme that is going to be increasing in a patient having myocardial infarction happens to be myoglobin. In fact, as and when we are writing the term myocardial infarction, M and I, so M will always help you remember that's myoglobin. I is the first that we are going to be writing in the Roman numericals. So the first enzyme to increase in myocardial infarction happens to be myoglobin. Earliest enzyme to increase in this situation. The problem, however, with this kind of an enzyme is that the level of this enzyme is going to increase in a short span of time, and the level of this enzyme comes back to normal within a duration of 24 hours. Also, let us just recall that myoglobin is an example of a protein that is going to be present in the muscle tissue. So it is not something which is going to be an absolutely specific enzyme for making a diagnosis of only and only myocardial infarction. When we talk about enzyme number 2, that is what is being given the name of the creatine kinase enzyme. This particular enzyme is going to be having multiple isoforms as we understand. The different isoforms of the enzyme are going to be the CK-MM isoform, that is what is present in the skeletal muscles. We do have the isoform that is present in the cardiac tissue which is given the name of CK-MB form. And we do have the isoform of this enzyme that is present in the neural tissue or the brain tissue which is the BB form. So the important fact which is worth remembering over here happens to be a simple situation that out of the three isoforms, it is the CK-MB form of the enzyme that is useful for making a diagnosis of myocardial infarction. However, it is important for us to understand that this CK-MB form of the enzyme can be increased not only in myocardial infarction, it can also be associated with something like myocarditis or myocardial inflammation. So CK-MB form of the enzyme increases both in myocardial inflammation, that means myocarditis. It can be increased in myocardial infarction as well. Talking about enzyme number 3, about which we need to definitely have an idea when you are talking about being physicians in today's times, that's the troponin enzyme. We have got two important subtypes of the troponin enzymes, the cardiac troponin I and the cardiac troponin T. Please be familiar with the fact that the importance of knowing about these enzymes lies in the fact that these enzymes are going to be present in an elevated concentration in a patient suffering from myocardial infarction for a long duration. So these enzymes are going to be taking something like 24 to 48 hours for their concentration to get increased. But the important fact that we need to remember over here would be a fact that these kind of enzymes are going to be elevated for a duration of something like 7 to 10 days. Levels of these enzymes are going to be elevated for a duration of 7 to 10 days. So their levels actually start increasing within a duration of few hours, let's say 24 hours. The peak levels are attained at 48 hours and their levels are going to be elevated for such a long duration. Why that becomes significant for us to understand is because of two reasons. These are, as on date, the best enzymes for making a diagnosis of myocardial infarction. Why we say they are the best enzymes for making a diagnosis of myocardial infarction lies in the fact that this particular enzyme happens to be extremely sensitive. This also happens to be extremely specific. So the most specific enzyme responsible for making a diagnosis of myocardial infarction happens to be cardiac troponin enzymes. The most specific enzyme responsible for making a diagnosis of myocardial infarction is troponin again. So sensitive as well as specific. The other important fact that we need to understand regarding these enzymes, which is new information as of now, when we have a situation like a patient suffering from a second attack of myocardial infarction within a span of, let us say, 3 to 4 days. This is a condition that is going to be given the name of reinfarction. So say for example, I had a patient who was suffering from myocardial infarction, and this patient was admitted in the CCU, that's a coronary intensive care unit. And now after 4 days of admission, this patient again has a complaint of a chest pain. This can very well be because of a second attack of myocardial infarction. What we do in such a situation is that we are going to be taking the blood sample of this individual again, and we are going to be having an estimation of the cardiac troponin enzymes. So if we are going to be doing a quantitative test, it will always help us to establish the fact when the level of the cardiac enzymes are going to be increased. If there is a second attack, the level of the cardiac troponin enzymes is going to increase further, and that is why it is going to be useful for making a diagnosis of reinfarction. So for 3 important questions that they put up to you on your exams, the most sensitive and the most specific enzyme for making a diagnosis of MI, as well as the best enzyme for making a diagnosis of reinfarction, the answer of choice happens to be something like the troponin enzyme. We hereby also need to reiterate the fact that when we have a comparison between the 2 types of troponin enzymes, the cardiac troponin T and cardiac troponin I, it's the cardiac troponin I which happens to be more important. And that's fairly easy for most of us to recall at the time of exams as well, I for important. So it's a more important subtype of the cardiac troponins which is useful for making a diagnosis of myocardial infarction. Talking about the next important enzyme, which happens to be the LDH enzyme. When we talk about the LDH enzyme, this is going to be having multiple significances. Significance number 1. When we talk about the LDH enzyme in a normal individual, what we find is that the LDH enzyme isoform subtype 2 is going to be having a greater concentration in comparison to LDH enzyme isoform subtype 1. LDH2 is greater than LDH1 in a normal person. However, in a patient who is going to be suffering from myocardial infarction, what we find is that the LDH1 concentration is going to become higher. So in a normal person like you and me, the LDH1 is going to be lower. But if God forbid we are suffering from something like myocardial infarction, the LDH1 concentration is going to increase. How can we remember it? By the same fact again, myocardial infarction I is going to be resembling the first of Roman numericals. So LDH1 is what is going to increase. Why that becomes important for us to understand is because this kind of a change in the ratio. Normal individuals, LDH2 is more. Heart attack patients, LDH2 becomes less. So the ratio gets reversed. And this kind of a phenomena is what is being given the name of the flipping of the LDH ratio. Flipping of the LDH ratio. So patients suffering from myocardial infarction are going to be exhibiting the phenomena of the flipping of the LDH ratio, which practically means, and talking about that for nth time over here, LDH1 concentration is going to become far more higher in comparison to LDH2. That's the first significance of knowing about LDH. Fact number 2 that we'll have to put up as a question on the board, LDH is the last enzyme to increase in a patient suffering from myocardial infarction. So the first enzyme to increase was myoglobin. The best enzyme happens to be troponin. And when we are talking about the last enzyme to be increasing in a patient suffering from myocardial infarction, that happens to be LDH. Significance number 3 for the LDH enzyme is a fact that LDH is an example of an enzyme that is present in the normal cardiac tissue. Say for example, if I say that this is an example of the LDH enzyme that is present intracellularly in a normal cardiac tissue, this LDH enzyme has an important property. This can be reacting with a chemical that is being given the name of triphenyl tetrazolium chloride. triphenyl tetrazolium chloride. So if we apply this particular stain, triphenyl tetrazolium chloride, in a normal cardiac cell, the intracellular LDH enzyme is going to be reacting with TTC, and once it is going to be reacting with TTC, it is going to be giving a brick red color. Normal cardiac tissue is going to be having the presence of the LDH enzyme inside it, which is going to react with the triphenyl tetrazolium chloride, and therefore it is going to be giving you a brick red color. We can very well understand a situation in which a patient is going to be suffering from, let us say, myocardial infarction. And if a patient is going to be having myocardial infarction, as we had talked about earlier, this is going to be characterized by damage to the cell membrane. So the LDH enzyme is now going to leak out from inside the cell to outside. If it is going to leak out from inside the cell to outside, when you apply this kind of a dye, the triphenyl tetrazolium chloride, you are going to be getting a pale color or a yellow color. So why that becomes important for us to understand is, say for example, you have a situation in which a patient has died suddenly. Now, in order to establish the fact whether the patient had actually suffered from an infarction of the cardiac tissue or not, what you can do in these patients is, you can simply apply this kind of a stain or a chemical which is given the name of triphenyl tetrazolium chloride. If the patient had not died because of infarction to the cardiac tissue, you are going to be getting a brick red color in the cardiac tissue. On the other hand, if the patient would have suffered from something like myocardial infarction, the infarcted area is going to be giving you a pale color or a yellow color. In fact, that is essentially what is being used to identify the infarct area in the specimens as well. So when you're looking at the heart tissue or the cardiac tissue as a whole, on the application of this dye, the triphenyl tetrazolium chloride, wherever you are having the presence of a paleness of the tissue or an whiteness of the tissue or yellowness of the tissue, that's an example of an infarcted area. The viable tissue or the normal tissue is going to be giving you a brick red color. So that's the third thing that they'll have to ask us on the board exams with respect to something like the LDH. So last enzyme to increase your myocardial infarction, associated with something that you give the name of flipping of LDH ratio, and you associated with the staining pattern associated with a dye that is given the name of the triphenyl tetrazolium chloride. A third way of making a diagnosis of myocardial infarction that we can talk about over here in a real world situation happens to be something like the echocardiography. Whenever there is going to be presence of an ischemic damage to the cardiac tissue, we are going to be picking up it with the help of something like hypokinesia of the ventricular wall. So this damaged area of the ventricular wall cannot be having the synchronous movement with the rest of the ventricular wall, and therefore it is going to be having a reduced activity. Hypo means less, kinesia means movement, so less movement. There is a possibility if there is going to be an infarction, this is going to be seen with zero movement of the affected tissue, so that can be picked up on the echo again with the help of something given the name of akinesia. Provided we are going to be having the facilities, we always go in for something like the presence of sometimes radioactive scans, and the principle of the radioactive scans is what we're going to be talking about over here in a couple of minutes. So the scan that is being done in the patient happens to be something like the thallium scan. A very basic fact that we need to just be familiar with is thallium is going to behave in the same fashion just like potassium. So it's easy for us to understand maybe with the help of a diagrammatic representation. If we just talk about a normal cell, normal cardiac tissue, and let's say this is an example of a situation, myocardial infarction. If we are going to be giving or the thallium, it is going to be present inside the cardiac cells just like potassium. So thallium is going to be having a diffuse kind of a staining in the viable tissue or in the normal tissue. However, let us just assume a condition on the right side in which the patient has suffered from some kind of an infarction in this area. Why we are talking about this area is the viable tissue is going to be having the presence of thallium, but in the infarcted area, as it is easy for us to understand, the cell membrane is going to get damaged. If the cell membrane is going to get damaged, potassium is going to leak out. And just like potassium cannot stay inside the cell, similarly thallium cannot stay inside the cell. So when you're going to be doing a scan with radioactive thallium, what we find over here is that the infarcted area is going to be picked up quite comfortably it is going to be picked up against a background of something like the normal or the viable myocardium. So that is what is going to be given the name of the radioactive scan or the thallium scan. Just remember the principle, thallium is going to be behaving in the same fashion just like potassium. The other thing which is loved to be asked by the examiners on our board question happens to be the biopsy findings or the histopathological findings that we associate with myocardial infarction. These biopsy findings or histopathological findings are going to be seen dependent upon the time frames. So what we need to understand is that within the first 4 hours of myocardial infarction, you are not going to be appreciating any kind of a change in the cardiac tissue. No change can be seen in the cardiac tissue usually, except for the fact that maybe you can be having the presence of some kind of a swelling of the mitochondria. But in general, on the light microscopy or on the gross examination, no change can be appreciated. What we then need to be familiar with would be a fact that the next important change is what is going to be observed within the duration of 4 to 24 hours. With between 4 to 24 hours, what we find in these patients is that these patients are going to be having the presence of intercellular edema. And because of the presence of intercellular edema, what we are going to be finding over here is going to be the presence of waviness of the fibers. Waviness of the cardiac myocytes or waviness of the fibers. Grossly speaking, if you are looking at the cardiac tissue, the cardiac tissue is going to be having the presence of a pale area, which as we discussed few minutes back is something that can be picked up with the help of something like the triphenyl tetrazolium chloride. So within the first 24 hours, you are just going to be having an important finding that is asked on the boards, that is waviness of the fibers. So that becomes a high stuff for us to be familiar with when we talk about the changes that we see within the first 24 hours. The next important fact that we need to be having an idea is the change that we expect to see between 24 hours to 72 hours. That means between first to the third day, between 24 to 72 hours. What we are going to be getting over here is going to be an interesting fact that this is an example of a condition which is going to be associated with coagulative necrosis. So that is something which can be picked up on the microscopic examination. The other thing that we associate with coagulative necrosis is something that we have discussed in cell injury discussion. This is going to be characterized by the presence of neutrophilic infiltration. Neutrophilic infiltration. Grossly speaking, if you are looking at a specimen, the cardiac tissue is going to be having the development of an infarct. And this kind of an infarct classically is going to be having the presence of a yellow border. Why exactly are we going to be having the presence of a yellow border around the infarct is because of the presence of neutrophilic infiltration. So microscopically neutrophils are seen, there is a coagulative necrosis, and grossly also that correlates with the fact that you have an infarcted area which is going to be having the presence of a yellow border. What is interesting for us to know is going to be the change that we are going to be seeing after 72 hours. So between 3 to 7 days, what we find is that at a microscopic level, there is going to be an infiltration of the monocytes and macrophages. So neutrophils are going to be reducing in number. The monocytes and the macrophages are actually going to be replacing them. The other thing that we find over here in the gross specimen is going to be that this is going to be characterized by the presence of hyperemic borders. Hyperemic borders. Something that is attributable to the presence of the dilatation of the blood vessels in the periphery, because now the body is going to try to repair this kind of a damage. What we are then going to be talking about over here is going to be the change that is going to be appreciated at the level of 7 to 10 days. And at this kind of a level, at a microscopic level, what we see is that this is going to be characterized by the deposition of granulation tissue. Granulation tissue. Grossly, that is something that is going to be picked up with the help of the presence of the red to brown color margins. Red to brown color margins are going to be seen around the area of the infarct. And this is going to be grossly also seen with the presence of a depression of the scar. So there is going to be presence of deposition of the granulation tissue, which is going to be characterized by depression of the scarred area in the gross tissue. The next thing that we've talked about happens to be something that is going to be seen after many weeks have passed away. Classically, we say around a month or so. So around 4 to 6 weeks, what we are going to be having over here is going to be microscopically, you can be having the presence of a collagenous scar. And grossly also, that is something that is going to be correlating with the help of a gray to white scar. This is logically going to be associated with a deposition of lot of fibrous tissue. So what we just need to be familiar with is going to be a simple fact that when a patient is going to be suffering from myocardial infarction, there is going to be a sequence or set of certain changes which can be appreciated at a microscopic level as well as grossly. Why do we need to remember about these changes? Is because of the kind of questions that they put up to us on the boards. Say for example, they give you a question that there has been a person who has been found dead by his neighbors. The forensic team comes over there and they try to investigate the cause of death of this guy. What they find on the autopsy of these patients is that this patient is going to be having, let us say, the presence of a hyperemic border around a pale area of the heart. So if you're going to be having the presence of a hyperemic area on the gross examination around the cardiac tissue, that means the patient has died anywhere prior 3 to 7 days prior to when he was found. Microscopically, let me say that the patient was having the presence of something like granulation tissue. So that means the patient had died around a week to 10 days back. If I find only that there is presence of something like waviness of the fibers, it always gives me a hint that the patient has died within 24 hours. So all those have been asked in our exams in different ways in terms of the board questions. We must also remember a very keen fact, and that is within 24 hours, you're going to be having the presence of the waviness of the fibers. Between the first and the third day, that means the first 72 hours, you're going to be having the presence of neutrophilic infiltration. But just after 72 hours are going to be lapsing, you're going to be having the presence of something like the macrophages infiltrating. So that 72-hour time frame is something which is loved by the board examiners to be asked to you as a question. Other thing about which we need to have an idea, which is sometimes put up to us on the exams, happens to be a situation which is going to be given the name of something like the reperfusion injury. Under normal circumstances, if I have a patient who is going to be suffering from a cardiac ischemic injury, if I happen to give to these patients something like the thrombolytic therapy, let me say something like streptokinase or maybe something like alteplase or urokinase, I expect to open up the blocked coronary vessels of these patients. Majority of the patients are going to be having an improvement in their clinical manifestations. However, there is a small subset of patients in whom the administration of the thrombolytic therapy is going to be associated with worsening of their manifestations. This kind of a situation is what is being given the name of reperfusion injury. So once you are attempting something like a thrombolytic therapy, or you're doing something like a coronary artery stenting, or you're doing any kind of an invasive procedure to actually increase the blood supply to the cardiac tissue, what we find in these patients is there is going to be a worsening of the manifestations that we see in the patients. Now this can be attributed because of the sudden influx of the white blood cells, the sudden influx of the formation of free radicals, or there is going to be an influx of something like calcium. What we find in these patients at a microscopic level, because of the more amount of blood that is coming over here, it is going to be bringing with it calcium, and this calcium is going to be responsible for causing contraction of the myocardial fibers. Whenever we are going to be having a contraction of the myocardial fibers in such a situation, that is something which can be appreciated microscopically with the presence of something which is being given the name of contraction bands. So once we are talking about something like reperfusion injury, and histologically we find the presence of contraction bands, both of them are going to be correlating with each other. So the extra calcium actually is going to be responsible for causing this kind of a phenomena, and clinically these patients are actually going to be having a worsening of their manifestations. So that is what we need to have an idea so far as the concept of contraction bands is concerned. We can now talk about the complications that we can see in a patient suffering from myocardial infarction. If we talk about the different types of complications that can be seen in a patient suffering from myocardial infarction, there is a certain set of complications which are more important than others. Complication number one, about which every physician needs to have an idea, every budding doctor needs to have an idea, is the development of arrhythmias. Arrhythmias. Why are the cardiac patients going to be having development of arrhythmias? That is simply because of the ischemic damage. Now what we need to be familiar with regarding this kind of an arrhythmia is going to be a simple fact. When you're talking about the arrhythmias in these patients, patients can be having an ischemic damage to the SA node. So they can be having a decrease in their heart rate. Patients therefore can be having the development of bradyarrhythmias. A lot of these patients unfortunately are going to be having the presence of ischemic damage which is going to be affecting the ventricular tissue much more severely. As a result of this fact, the patients are going to be having the development of ventricular arrhythmias. And why do we need to talk about that particular fact is one of these ventricular arrhythmias happens to be ventricular fibrillation. Let us just recall the fact that this ventricular fibrillation has the maximum chances of taking place within 1 hour of development of myocardial infarction. And why that becomes significant for you guys to remember is because of a simple fact that this ventricular fibrillation actually is going to be responsible for causing mortality in 25% of the patients. So 1/4 of the patients who are going to be suffering from heart attack or myocardial infarction do not live any further to see a second type of an infarction or a second trouble. It's a very huge number. What you need to be familiar with for that particular fact as a board question as well is that the reason for the death in these patients, the commonest reason happens to be the development of ventricular fibrillation. So you must always have an idea as a physician that if you happen to encounter a patient who is going to be suffering from myocardial infarction, within the first 1 hour, patients are going to be having the maximum chances of suffering from a mortality because of ventricular fibrillation. What can you do to help this patient out? Ideally speaking, you should be having the presence of something like a defibrillator or what is being given the name of cardioversion. If that's not available for some reason, say for example, you are working in a periphery or you do not have the presence of that device with you, please be familiar with the pharmacological agent which can be life-saving for these patients. That happens to be a drug like lignocaine. So ventricular fibrillation is the commonest cause of death in a patient suffering from myocardial infarction, especially within the first hour. Usually when the first hour has elapsed, then the patients are going to be having the development of something like ventricular tachycardia. So any type of arrhythmia can be seen in these patients, be it a bradycardia, be it a tachycardia, but reiterating that fact again and again, the reason for the mortality or death of these patients happens to be ventricular fibrillation. Fact number 2 about which we need to have an idea is going to be complication number 2. Patients could be landing up in something like cardiac failure. So simply because the pumping ability of the heart is going to get severely compromised, the patients can be landing up in something like cardiac failure. Fact number 3 about which we are going to be asked questions in the exam happens to be a condition which is going to be given the name of the cardiac rupture syndromes. Cardiac rupture syndromes. These cardiac rupture syndromes clinically in the patients are going to be most frequently seen between 3 to 7 days after suffering from an attack of myocardial infarction. Why that takes place has a scientific reason. Just during this particular time duration, 3 to 7 days after an attack of myocardial infarction, the cardiac tissue actually is the most vulnerable, it is most fragile. Because of the fact it is going to be most fragile, it is going to be having a higher chance of having a damage or a rupture. Now this kind of a damage or the rupture can be affecting 3 important areas of the heart. We can be having the involvement of something like the anterior wall of the left ventricular. So that can be something like a free wall rupture. Possibility number 2, we can be having a damage to the interventricular septum. Or possibility number 3, we could be having the presence of something like a valvular defect, mitral regurgitation, because of possibly the damage to the chordae tendineae. What we need to be familiar with for the purpose of a board question in our exam is the simple fact that it is a free wall rupture that is going to be most commonly observed in the patients. The significance of knowing about this kind of a fact also lies in a medicinal correlation. If the patients are going to be having a free wall rupture, what we can expect to find in these patients is going to be a situation in which the blood is going to be leaking outside into the pericardial tissue, and this kind of a blood is very importantly going to be filling up the pericardial space. So in a short duration of time, the blood fills up around the cardiac chambers, and this can be responsible for development of a complication that we read in medicine, the cardiac tamponade. This compromises the contractility of the cardiac tissue even further. So for the purpose of the exam, this time frame is what is very, very important. We need to be familiar with the fact that it is anterior wall rupture, which is going to be the commonest cardiac rupture syndrome that we find in the patients. And apart from them, the patients can be having a damage to the interventricular septum, as well as the patients can be having the presence of mitral regurgitation. The next important complication about which we must have an idea happens to be a condition which is being given the name of autoimmune pericarditis. Autoimmune pericarditis. What we find in a patient who is going to be suffering from something like myocardial infarction happens to be a situation that these patients are going to be having an exposure to new antigens, or there is going to be an exposure to what is being given the name of neoantigens. Classically, this kind of an exposure to the new antigens is going to be taking place 2 to 3 weeks after an attack of myocardial infarction. But in some patients, it has been reported to be taking place as early as between 48 to 72 hours as well. That means 2 to 3 days. Usually, it is 2 to 3 weeks time during which the new antigen exposure is going to be taking place. Because of the new antigen exposure, that is going to be responsible for causing activation of the immune system. And this activation of the immune system is going to be responsible for inciting an inflammatory response. So therefore, the condition is being given an important name. It is called as autoimmune pericarditis. Inflammation of the pericardium, which is going to be classically autoimmune in nature. So that's an example of a high yield stuff that they put up to us on the exams. The second important fact is that this condition is also known by a technical name. This condition is known by the name of Dressler syndrome. This condition is given the name of Dressler syndrome. So examiners love to go after this fact, autoimmune etiology. Examiners love to go after the fact, what's the time frame when you say this condition. Clinically, that becomes important because this is a patient who is going to be having a presentation of chest pain. You may actually confuse it with a second attack or something like reinfarction. But as we discussed earlier, it's the level of the cardiac troponin enzymes which are going to be helpful for differentiating between these two facts. Additionally, when we have a patient suffering from this kind of a situation, that's an inflammatory condition. So patients are going to be having a symptomatic relief when they are being given anti-inflammatory drugs. So NSAIDs are going to be helpful for the management of this kind of a condition, and the time frames and the etiology is what is supposed to be remembered for the purpose of the questions in the exam. Talking about the next important complication. The next important complication that can be seen in these patients can be something like ventricular aneurysm formation. Weakness of the ventricular wall because of the ischemia associated damage can be responsible for causing formation of a ventricular aneurysm. So just making a diagrammatic representation. And the problem that we have with this kind of a ventricular aneurysm can be twofold. Problem number one, this ventricular aneurysm actually is going to be providing a pocket or an area where the blood can actually stay for a longer duration. So it can be responsible for the formation of a clot or a thrombus. And possibility number two, because there is a weakness, there is every chance that this kind of a weakened area of the ventricular wall can actually rupture. If that rupture, that can be responsible for causing leakage of the blood through this area, might as well result in mortality in the individual. So these are the complications about which we need to have an idea so far as a patient suffering from myocardial infarction is concerned. That takes care of our discussion of myocardial infarction.
Now, when we talk about myocardial infarction, the patients are going to be having the development of an irreversible cardiac tissue injury because of development of ischemia. So what we are going to be finding in these patients is at a microscopic level, especially in the early stages, the patients are going to be having the presence of coagulative necrosis. Now, this coagulative necrosis is something that you can pick up with the help of the presence of hypereosinophilic muscle fibers over here. What you also find in these patients is that there is going to be presence of neutrophilic infiltration. Please recall the fact that when we are talking about myocardial infarction, the earliest change that we have in these patients happens to be the waviness of the fibers. Subsequently, that is going to be followed by coagulative necrosis, and then you are going to be having the presence of neutrophilic infiltration. As a concept, neutrophils are phagocytic cells, so they are going to be infiltrating this area so as to eat up the presence or the dead cells. The other thing that we need to recall over here is that till the first 72 hours, you are going to be having predominantly the presence of neutrophilic infiltration. But once 72-hour boundary has crossed in the timeline, what you're going to be getting over then is going to be the influx that is going to be seen because of the macrophages. So if you get an image in the exam like this, which is going to be having the presence of a lot of macrophages, then for sure it is an example of a myocardial infarction case in which the biopsy has been performed after 72 hours. What we also find is that if the biopsy of the patient is going to be performed at a time frame zone in 7 to 10 days, then you're going to be having the presence of something like granulation tissue. So something that is very, very important with respect to the time frame based questions in the exam, earliest change happens to be waviness of fibers. You are then going to be getting neutrophilic infiltration within 72 hours. After 72 hours, you're going to be having macrophage infiltration, and 7 to 10 days, you're going to be having the presence of granulation tissue. If you're looking at a cardiac biopsy tissue in a patient who has suffered from myocardial infarction at a level of 2 weeks, then you are going to be having the presence of the deposition of the fibrous tissue. We take this opportunity to just revise the fact that when we are talking about myocardial infarction, which is the earliest enzyme that is going to be increasing in these patients? Yes, that is what we discussed in the video section. That is going to be something like myoglobin. What is the best enzyme for making a diagnosis of myocardial infarction? That is going to be the estimation of the levels of cardiac troponins. Which is the last enzyme to increase in a patient suffering from myocardial infarction? Yes, that is going to be something like the lactate dehydrogenase enzyme. And I take that opportunity to revise with you the enzyme of choice for making a diagnosis of reinfarction. So that is again going to be answered as the cardiac troponins. So that is one thing that we need to be familiar with so far as the histological appearance of myocardial infarction is concerned. Now, sometimes in a patient who has suffered from myocardial infarction, you would like to give thrombolytic therapy, especially in case of something like ST elevation MI. Now, usually the thrombolytic therapy like streptokinase, alteplase, reteplase are going to be responsible for causing improvement in the symptomatic condition of the patient. However, what we find in some patients is that once you're going to be using thrombolytic therapy, that is responsible for causing worsening of the condition of the patient, and this is usually caused because of sudden massive influx of calcium, free radicals, as well as the white blood cells. Now, if there is going to be a massive injury or massive influx of calcium, presence of neutrophils and free radical induced damage, this is what is going to be manifesting in the form of presence of such contraction bands. So you are going to be finding dark pink areas as I'm going to be representing with the rotating dot for you. This is going to be the presence of contraction band necrosis. So this contraction band necrosis is what you are supposed to remember is what is going to be a key finding that you associate with the patient who is going to be suffering from reperfusion injury. So that's a high stuff that we need to be able to be recalling in the exam with respect to the images, particularly with respect to myocardial infarction. The other important thing that we can be asked in the exam, and that has been asked theoretically so many times earlier, in a patient who has suffered from myocardial infarction, if I'm going to be performing an autopsy and I'm going to be using a special stain that is going to be given the name of TTC, that is what you can recall from the video lecture as well, triphenyl tetrazolium chloride. TTC is an example of a chemical which is going to be reacting with lactate dehydrogenase. So in case of viable cells, we are going to be getting the presence of a red color, but in the area where you're going to be having the presence of infarction, you're going to be having the leakage of the LDH enzyme, and because you have a leakage of the LDH enzyme, this particular area or the affected area over here is going to be pale in color. So once you are going to be having the use of triphenyl tetrazolium chloride, particularly in case of a cardiac biopsy in a patient or the cardiac autopsy in the slices, cardiac slices, this is what is going to be helpful for localizing the area affected by myocardial infarction. That is what we need to have an idea so far as the important questions with respect to myocardial infarction are concerned.